Dr. Praveen, good morning. You can start the presentation.
Morning, sir. I'm audible, sir.
Yes, you are.
Yes. Okay. So, morning, everyone. I'll be speaking about the current advances in the management of distal radius fractures.
I hope it can be maintained.
Just a quick recap of the anatomy, what is currently being followed for while approaching distal radius fracture. As you know, currently the most commonly followed concept for approaching a
1 minute,
fracture.
Praveen. 1 minute. Praveen, 1 minute. Dear listeners, kindly mute your mic, please. Please mute your mic. Thank you. Continue, Praveen.
Yes, sir. So currently all fractures are approached according to a column concept. So basically, the column concept divides the distal radius into functional 3 osteoligamentous columns with various structures comprising each column. So as soon as comprised of the radial column and the intermediate column and the ulnar column, which predominantly just consists of the ulna. And with the radial and the intermediate column sitting onto the pedestal, which is the metaphyseal diaphyseal junction of the distal radius. So again, the quickly regarding the important constituents of the column, the radial column consists of the radial styloid up to the scaphoid fossa, and the musculotendinous elements include the brachioradius tendon and the long radial lunate as the radial scaphocapitate ligaments. The primary function of the radial column is only to provide a buttress for the radial movements, in particular in deviations, both ulnar and radial deviations. So, point to note is that if it is a primarily axial loading due to distal radius, the radial column might sometimes be spared. Coming to the next more important column, which should be more particularly concerned about, is the intermediate column, which consists of the lunate facet articulating with the lunate and the sigmoid notch articulating with the distal ulna. The other ligaments include the short radial lunate ligament, as well as the volar distal radial ulnar ligament, as well as the dorsal radiocarpal ligaments and the dorsal distal radial ulnar ligaments. Again, this is a primary restraint for dorsal subluxation of the carpal bones. So, and this column can be fractured by multiple mechanisms, particularly during axial loading. Can also get fractured with shear fractures and bending forces on the distal radius. Point to note is that, and if there is a intermediate column height loss of more than 10 mm, it invariably signifies there is associated injuries of either the DRUJ or the TFCC. So, just a quick points to be kept in mind while intraop reconstructing distal radius, that we should aim for anatomical reduction of the intermediate column, that is the lunate facet, even if not for the radial column. Few points to be kept in mind is the LLFR ratio. That is nothing but the lunate to the lunate fossa ratio. This is basically to make sure we attain the congruence, either more primarily for both pre-op assessment as well as intra-op assessment, to make sure we achieve adequate reduction. We should make sure the congruence is similar. That is lunate width and then width of the lunate fossa is around 1. I mean, the ratio of the lunate width to the lunate fossa is around 1. If there are decrease in the width, that is, if the lunate fossa is wider, if it is less than 0.94, implies up to 2 mm gap, and if it is much lesser, that implies the articular reduction is not adequate. And also, another point to be noticed, the method of teardrop angle, which is taken a 10-degree lateral view. We want to check the angle it makes with the distal radius axis, which again is a guide for intraoperatively to check our adequate reduction. So as discussed, the pedestal is the metadiaphyseal segment, and this usually presents most distal radius fractures. If there is a fracture involving up to the pedestal, it invariably implies a very high energy injury. So coming to the current indications for surgery as per AAOS in 2021. So the acceptable deformities and include tilt of if there is dorsal tilt of up to 10 to 15 degrees. I mean, unacceptable deformities which need surgical correction is dorsal tilt of 10 to 15 degrees, ulnar shortening of 2 to 5 mm. There is loss of radial inclination of less than 15 mm, and of course any intra-articular step off. Even if the patient presents with the initial deformity, the current concept is give a hematoma block and try to achieve a reduction and get a check X-ray done. If there is adequate volar contact, then the conservative can be attempted with, of course, serial follow-up. And of course, in serial follow-up, if there is any recurrence of this parameters, invariably is a candidate for surgery. Of course, definitive indications include fracture dislocations and open fractures and concomitant fractures. So coming to the recent advances with implants with respect to distal radius. So where we stand with respect to distal radius locking plates. This is the most commonly used implant. So as we all know, we have used the variable angle locking plates available, where with this is a change in the screw hole orientation, which allows for a 15-degree toggle in multiple directions, thus allowing for variable angle locking. And more importantly, what's currently available is this fragment-specific plates for distal radius. So these are some of the few types of plates available with the radial column plate, with the pin plate, isolated radial column plate, and multiple hook plates, particularly for using for fixing very small fragments. So what is the pitfalls of fragment-specific plates is that a little more technically demanding than the conventional water locking plates, and also additionally it requires additional exposure and additional exposure. Hence, it's usually time-consuming, and if mostly it is used for dorsal column fixations and invariably needs an additional incision. And however, most studies have shown there is definitely better maintenance of reduction with the use of mini fragment fixations as compared to conventional locking plates. So what are the other recently available implants? Is that first we have this distal radius nail, which is, as you know, is has a fixed angle locking, fixed angle distal locking for the subchondral surface of the bone, and a proximal diaphyseal interlocking for rotational stability. Distal radius nail has again very limited indications. It is indicated for a simple extra-articular without much combination, as well as simple intra-articular fracture. The implant as such is found to be more stable construct as compared to the wall locking plate. These are some of the types of nails currently available. This is the AVO nail, which is recently introduced into the market. And these are some of the other nail systems which are available. So just quickly about how to go about distal radius nailing. So with the incision is placed over the radial styloid, and the deep dissection is done to look for and isolate the sensory branch of the radial nerve. And once that is done, the plane is developed between the first and the second extensor compartments. And just next similar steps to nailing is done, broaching is done, nail is inserted, and then that's locked. So what are the possible complications of the distal radius nail? Primarily with the initial exposure site, there's a risk of superficial radial nerve injury or irritation. And of course, since it's a fixed angle constructs, if there is slightly varied anatomy, or if the reduction is improper, there might be screw penetration into either the radio-ulnar joint or into the radiocarpal joint. And also there have been higher reports of loss of reduction with respect to nails as compared to plates. This is particularly with respect to when trying to address very small fragments. Since the small, say in very extensively comminuted fractures, there's loss of small articular and as well as extra-articular fragments, which are maintained better with the plate. So this is the current status with respect to distal radius nails. These are the few notable studies available. There's only one study with with around 80 patients of nails against 70 patients of plates. It's a randomized control study with 2-year follow-up, showing good results, showing just only one case of screw penetration and however higher incidence of sensory neuropraxia. Again, there's one study by Plate et al. Published in Journal of Hand Surgery. This is again a RCT, which showed there is a loss of reduction with the use of nail as compared to a plate, particularly with small extra-articular fragments. So the next device is the intramedullary cage. This is so how this device works is that it is basically an intramedullary expandable implant. So what it does is it makes up for the bone loss as well as provides support intramedullary to maintain the reduction. So and this scaffold hence can be used for fixing the extra-articular fragments onto the scaffold, like with the scaffold using a screw. So this is made up of ninitol and makes use of its temperature dependent properties. So it is usually in its compressed state before being introduced into the bone. So it can be introduced in a compressed state, and once into the cavity, with its reaction to the body temperature, it expands to its current size, to its expected size, and then it can be stabilized onto the bone. So just again quickly about the surgical technique. So all the steps, initial steps are similar to nailing. Reduction and preliminary KY fixation should be done by traction and indirect reduction techniques. Following which KY should be placed just ulnar to the listless tubercle. This is the guide KY. Using this guide KY, a template, this template is used to mark the entry point for the device. And then again, a deep dissection is done at the entry point of the device, either radially or dorsally. While if carrying a deep dissection, yeah. So this is a template which helps us to, this is a guide which helps us to locate the incision. Again, while looking for while doing deep dissection, we should be careful of the superficial radial nerve as well as the lateral antebrachial cutaneous nerve. Following which, 2.5 mm side cutting drill is used to drill the first cortex, and the canal is broached and prepared, and the cage is inserted and locked in its expanded position, and the side plate is applied. Finally, small screws can be used to fix the fragments onto the scaffold. So this is again indicated only for extra-articular and simple fractures. This is how a scaffold, cage looks in its expanded position. This has already been used for certain proximal humerus fractures. It seems to be very recently introduced for distal fractures. So main proposed advantage is the cage is that it prevents collapse. It gives adequate subchondral support since it's a seats as a construct within the intermedullary cavity. And like the nail and contrary to the plate, it's a load sharing device. And the intramedullary placement allows for lesser chance of hardware irritation with the surrounding soft tissue, and minimally invasive as compared to exposure for a plate. However, the prominent disadvantages include hardware removal, which can be complicated by both overgrowth of bone at the side plate side as well as significant ingrowth of bone into the scaffold. So they have reported removal is relatively atraumatic or not a complicated process, but I couldn't come across how they go about the removal. So again, possible complications include the incision site morbidity and possible tendon irritation. So not much studies are available. There's only one biomechanical study, and there's one series published in Journal of Hand Surgery with 100 patients. Again, most common complications include nerve irritation. No case of non-unions or infections. Next, coming to the peak locking plates. This is just the more modified versions of conventional locking plates. Sorry. So peak plate, use the peak plate with a titanium screw. So indications are just as similar as the locking plates. The primary advantage is the radial lucency of the peak plate, which helps for both intra-op and post-op fracture, intra-op reduction as well as post-op fracture evaluation for healing. This radial lucency can also be proved to be counterproductive in the initial plate positioning. Hence, the new plates coming with the distal tip markers for locating the tip of the plate for intra-op positioning. Another main advantage is that it has a low interference compared to metallic plate with respect to artifact generation when the patient is subjected to MRI or CT. And the next thing is its elasticity is similar to a cortical bone, that is less stiffer than an water locking plate. Hence, it has lesser stress shielding and lesser incidence of refracture. Hence, it is supposed to be better. It's easier for implant removal peak plates as compared to the conventional plates. And also, since we are using metal screws on a plastic plate, there is no chance of cold welding at the screw plate interface. The primary disadvantages include that, again, because of the stiffness of the plate, it is not as stable construct as the conventional plate. Hence, few reports of pseudoarthrosis and non-union have been reported. And again, because of the wear and possible local inflammation with the debris material from the peak plate. Other disadvantages of while using a plate like a tendon rupture and relatively more excess exposure as compared to a cage or a nail. So this is how an X-ray of a peak plate used with the titanium screws would appear. So again, current status, only very few studies are available. Just one is a randomized control study, 15 versus 15, and very relatively less follow-up. Only short-term follow-ups and long-term effects of use of peak and the possible wear effects have not been mentioned. Other possible implant is distillary semi-arthroplasty. So again, very limited indications, primarily reserved for very unreconstructably comminuted and severe osteoporotic bones with intra-articular extensions, or case with failed distal radius ORIF. So again, surgical technique similar to the conventional dorsal approach. Between third and fourth compartment, epiphyseal metaphyseal resected, the canal is prepared and either cemented or uncemented implant is used. If the ulna is not able to contour onto the hemiarthroplasty implant, a resection of the ulna is recommended. So primary advantage is a simpler procedure in severely comminuted fractures and hence allows for early stability and early ROM. Main disadvantage is that there is possible chance of wear of the proximal toe since there's metal on cartilage articulation and possibility of implant loosening as well as any processes. And there's also a risk of carpal instability with repeated movements against the metallic surface. So again, very limited studies. We have a reasonable follow-up to 32 months and 25 months. They reported a good early results and even long-term results are still awaited. So to summarize, these are a few of the most recently evolved devices for treating distal radius fractures. So as you can see, both the intramedullary nail and intramedullary cage have very limited indications, primarily for only extra-articular and simple intra-articular fractures. While addressing complex intra-articular fractures, there seems to be no substitute to the Woodard locking plate as of now. Again, with the Woodard locking plate, probably peak plates can be used because of the other related advantages of peak. And the distal radius hemiarthroplasty is reserved for comminuted intra-articular fractures with severely osteoporotic bone and possible distal ulnar fractures. So coming to the primary advantages of intramedullary nail and intramedullary cage is they have a relatively smaller dissection as compared to a distal radius plate. So there are smaller incisions. And with respect to peak plates, there is no risk of cold welding between the screws and the plate, and there's low artifact interference with MRI. And of course, distal radius hemiarthroplasty allows for early range of movements. Coming to the most important disadvantages, so there is increased loss of risk of loss of reduction with intramedullary nail, particularly small extra-articular fragments. And more importantly, with intramedullary cage, is since it's a very bulky space-occupying device within the medullary cavity, there are increased concerns of possible bone loss during hardware removal due to excess bone growth onto the implant. And with respect to peak, again, these are using metal screws on a plastic plate. So hence, there are limited attempts at redirecting the screw if in case of a malposition screw. And again, with respect to distal radius hemiarthroplasty, this is already we are removing the bulk of the distal radius, and hence there is an increased risk of bone loss if a further salvage is considered, like to replace the process. So another aspect being looked into is the use of bone graft substitutes in acute fractures. It is again still remains controversial. So again, indications is for a very osteoporotic and severely comminuted fractures with severe metaphyseal bone loss, which you probably would expect to collapse. They are not used in isolation. They are used in adjunct to volar locking plates usually to fill the metaphyseal defect if present after fixation. Autografts are preferred only for non-healing cases to restore the biology. However, there are good results seen with calcium phosphate cement augmentation and HA augmentation shown in these two studies. They shown good, again, but very less follow-up, but they shown good results with the use of bone graft adjuncts. This is an example of a HA being integrated into the distal radius defect following fixation. And finally, with the use of arthroscopy with respect to distal radius fractures. So primary advantage is that it allows for better magnification visualization and helps in accurate reduction of the fracture. And also any harder penetration if present can be visualized much better intraoperatively with the use of an arthroscope when in doubt with fluoroscopy. And more importantly, can help to diagnose TACC injuries when in doubt. And the primary disadvantage with respect to arthroscopy is the possible risk of compartment syndrome, which again can be circumvented if we are using bryscopy. And with respect to the treatment of associated injuries in distal radius, so the indication for an arthroscopic exploration is just the presence of bilaterability following fixation, which invariably implies a possible TFCC injury. If all distal radius fractures should be checked for allotment after primary fixation, and if found unstable, and scopy can be done to look for any possible tear in the TFCC. With respect to TFCC, there have been good results with TFCC repair, even if done after 1 year after post injury. So even probably missed in the initial surgery can be done at the time of implant removal. So either arthroscopic or open repair of TFCC can be done. If reconstructive TFCC done, then palmar longus or easy slip can be used. So take home message: the current concept for approach to distal radius is the fragment specific approach with the utmost importance to restoring the intermediate column. At present, there is no substitute to the volar locking plate fixation for complex interarticular fractures. And arthroscopy assisted fixation definitely has better results in assessing the intra-op reduction as well as for the diagnosis of other associated TFCC injuries. And in extensively comminuted and severe bone loss conditions, bone grafts or bone augments can be considered. Thank you, sir.
Thank you, Praveen. That was a very good presentation. Any comments on or any information on the dorsal distal radius plates?
And I mean,
because
more
there
of
seems to be these plates available in the market, but the problem is if it is not a good, very well contoured plate, because they try to place it next to the Lister's tubercle, and this plate, when because of the dorsal chip fractures or the dorsal Barton, usually this plate causes a lot of hardware related complications and extensor tendon ruptures and severe stiffness. Any comments on that?
I'm not sure, sir. I didn't read up much about it, but I think everyone is like trying to use this very mini
column
fragment plates to avoid the disadvantage of conventional dorsal plates.
Totally agree with that, because I have seen a few of the trauma surgeons who tend to fix each and every column of the distal radius individually with plates. So what will happen is if the soft tissue dissection is not meticulous, and if there is any implant prominence, the most commonest complication is X-ray will show a very good reduction of the fracture, but functionally the patient will have a stiff wrist, which does not serve the purpose. So in that case, it's acceptable to have some amount of malunion or deformity in the wrist with a moving wrist, rather than having a congruous distal radius with a stiff wrist. That's a problem for the patient. So you have to decide what is better for what group of patients. Usually distal radius fractures are majority treated conservatively as long as the radial tilt and radial deviation is maintained normal. Now, the one problem is the balancing force, that is the flexor and the extensor tendon forces which are to be balanced with the cast application. And if that is not satisfactory, if there is more than 2 mm displacement, then we have to fix it up. The problem that comes here is usually in osteoporotic bones where the collapse happens within the cast. Now, we know that we have to either use a K-wire or a distal radius plates, which will give the expected result. But this intramedullary cage fixation, I think it's primarily used for the distal radius benign tumors like GCT or the ABCs, where there is enormous bone void, which is filled up with this cage and the artificial bone grafts. Am I right?
Yeah, but I think it is being expanded for the use with respect to this also, sir, for fractures also, primarily for bone loss conditions.
Yeah, that's the one. So, but use of distal the radius nail, I don't think it is serving its purpose, because it has got its own complications, and nothing can overcome the benefits of a plate. The plate is the best, I would say. But keep in mind, yes, of course, you have to make sure that two things are to be taken care of. One is the carpal alignment. Now, if there is malunion, then there is carpal instability. And the most important another factor that you have to look into is the distal radial ulnar joint congruity. Now, if that is having a positive ulnar variance or negative ulnar variance, then the patient is going to have severe problem with respect to supination and pronation, which is day-to-day activities, taking the food and eating. So you need supination, pronation. So that has to be taken care of when you're trying to do it. And always after you fix the fracture, check with CM the stability of the DRUJ. If it seems to be more subluxing or doubtful, then it's always better to supplement it with K-wire fixation and then a cast application. This is always to be done mandatorily. The another factor is use of the column plates I wouldn't agree with the column plates in all scenarios. You will always see some cases like the die punch fracture, where the intermediate column would have been depressed to a certain extent. But if the reduction is acceptable, better to leave it as such and then start with the rehabilitation, because it's a non-weight bearing joint. The most important problem is patients who are involved in loading activities, especially manual laborers or people who are involved in gym activities where they load the wrist, and those are the people who are going to have some amount of arthritis in the wrist if there is incongruity. Column plates should be restricted to people who are involved in loading activities of the wrist joint.
Okay, sir. So we just had maintain how much a reduction with the volar locking plates, right, sir? As much as
if you're able to maintain the radial column reduction and the DRUJ symmetry, that is more than enough.
Yes, sir.
As for the recent advances, any role for external fixator for enclosed fractures? Maybe in osteoporotic or severely committed.
I mean, I came across it, but nothing mentioned as recent, as in same concepts for where we feel it's reconstructable. X-fix is being used for ligamentautaxis. That's it. Nothing. No.
So you mean X-fix alone or X-fix with some fixation?
X-fix with KY, sir.
Whenever recent literature comes up, they don't talk, even the AO concepts, they don't talk about KYS at all. But there is a good role for KYS, and I mean, maybe external fixator. Is that what's the literature currently? AO does not talk about KYS at all.
Yes, sir. They are advocating use of cannulated screws in place of KY for supposed possible pin site infections. I don't know if
So, I mean, if you had seen last time when Darshan's talk was, he was talking about something called the spring wire concept or something, where he places a K wire, bends it, and puts a plate over it. But AO doesn't talk about it. All for the small mini fragments, 1 mm KYS, bend the wire and put the plate over it. I forgot the name. Was it spring plate concept?
Yes, a spring plate concept.
Any, I mean, does the company talk about it?
No, so I didn't come across I went to a few articles. I didn't come across that being mentioned for distal radius. I'll look for this.
We can proceed to the next talk, please.
Yes, sir. Thank you, sir.
Sir, am I audible?
Yes, Rahul.
So I'll be talking about arthroscopy assisted distal and radius fractures. So this has come into play back in 1992 by this article Terry Whipple, who had popularized role of arthroscopy in treating wrist injuries in athletes. This was just a case report initially, and later on this was a case series of 7 patients with 2-year follow-up by Wolf et al. And he found all the 7 patients returned back to the previous job, and there was no evidence of any arthritis, and the target of less than or equal to 1 mm of step off was achieved in every case. So this was published in 1995. So this is into work since the early 1990s, and this it's basically indicated where we cannot achieve the 1 to 2 mm step off or the intraarticular congruity, and there is even enough evidence out in the literature to suggest that if there is more than 1 to 2 mm incongruity at the articular surface, there is increased propensity to develop an traumatic arthritis, post-traumatic arthritis. And arthroscopy in fracture fixation can be used as both diagnostic and a therapeutic tool, and it gives us a well-lit, magnified view of the distal radial joint surface with minimal mobility. So why arthroscopy? So it gives us enough picture about the biconcave distal radius articular surface, the concavity of the scaphoid and the lunate. It cannot be similarly seen in case of an image intensification like a CM. So because the differentiating feature of both these biconcave part of the distal radius articular surface is not well conquered by CM. And there is always a chance to address the chondral defects, the loose bodies, if at all any, and individually assess the fracture fragments intra-articularly and reduce it and fix it. And there is evidence of arthroscopy being helpful when combined with percutaneous spinning and is combined with external fixation and other limited open reduction techniques. So the most commonly indicated reason being intercarpal soft tissue injuries. When it is associated with intercarpal soft tissue injuries, the fractures, arthroscopy plays a vital role in treatment of these injuries. This article in 2001 by Edwards et al. In Journal of Hand Surgery, he did a comparative study and he found that 33% of the cases which were optimally reduced by C-arm, they found to have an articular displacement of more than 1 mm by an adjunctive arthroscopy. So that 33% is a huge number. And this article in Arthroscopy 2004 by Rush et al. They found that arthroscopy, when used as an adjunct, improved the overall range in terms of supination, wrist extension, and wrist flexion. Although that being said, the radial shortening and the overall functional scores were similar to both the groups when arthroscopy assisted was used as an adjunct and when it was not. And this is an article by Saab et al. In Orthopedic Traumatology Surgery Research in 2019. This was a systematic review including 720 patients, and they had a follow-up of up to 38 months. And 16 studies were included, and all were level 2 to 4 studies. And most of the studies were in the favor of arthroscopy to improve articular reduction and not the functional outcome. Overall, the functional outcome was similar, but to improve the articular reduction, they recommended arthroscopy. So when to do this? Whenever we get an intra-articular step-off after reduction in a C-arm, it is indicated to do an arthroscopy assisted reduction to decrease this step-off. And in unstable or displaced or intra-articular fracture where it is a lot of combination, it is indicated. And radial styloid fractures with associated injuries of the intercarpal ligaments, and lunate die punch fractures, 3-part T fractures, and Malone 4, where there is component of coronal and sagittal fracture orientation. And when all these fractures are associated with intercarpal diastasis and subluxation of DRUJ, and the carpal arch is broken as well. So when not to do this, in patients who have low demand and an osteoporotic bone, and when there is evidence of infection and there is CRPS, is definitely contraindicated. And in case of trauma entities, open fractures, and when there is median nerve injury and there's compartment syndrome and unreduced carpal dislocations, extra-articular fractures in elderly, and distal radius fractures associated with other multiple fractures, it's relatively contraindicated. So how to go about this? First, what the surgeon does is temporarily fix the fracture, whichever way he wants, either extra-articular external fixation or an internal fixation, and use K wires to attain articular congruity, and see under image intensification, if there is an articular step-off, then we scope it and then achieve articular congruity, and then fix it again with the aid of arthroscopy and then scope it to ensure that there is reduction is maintained and there is a final screw portion at the subcondylar screws are not into the joint. And also address the associated injuries later on, like scapholunate ligament injuries and lunotricutal injuries. So when to do this? So surgery is usually performed 3 to 7 days after injury, and they've reasoned it out with less than 3 days. If we do the surgery, there is high chance of visualization being difficult because of the hematoma. And after 7 days, the maneuverability of the individual fracture fragments can get difficult. And since they prescribe 3 to 7 days, and the position being patient lying supine with a tourniquet, and the traction tower being pulled with approximately of 3 to 4 kgs using these Chinese finger traps. So there are literatures gives both horizontal and vertical traction, but vertical traction is most preferred. And there is pneumatic tourniquet with S-march examination that is needed. Models there is high risk of fluid extravasation into the muscle compartments can cause compartment syndrome later on. And ringer's lactate solution is the best solution to use because of its rapid absorbability. And we use a 20 gauge needle and the proposed 3-4 portal for before incision. So when there is fracture, there is high likelihood that the portal placement can go wrong. So what is being suggested is we use a image intensification. We draw a line radial to the third metacarpal and a line radial ulnar to the fourth metacarpal. And this, where it intersects with the radial inclination line, is the point of which we use the 3-4 portal and the 6R portal. Because of the nature of these distal lattice fractures with a lot of swelling, the portal placement can be difficult, and this is a valid method where we can use it. What we generally use is a 2.7 mm probe with a 30-degree field of view angle, and the radiocarpal joint is usually assessed using 3, 4, 5, 6, and 6R portals, and the mid-carpal joints using the mid-carpal radial and ulnar portals. And the mid-carpal radial ulnar portals suggest distal to either of this 3, 4 and the 6R portals, and medial to both of these portals. 6U portal is used as an outflow to prevent any compartment syndrome. And the scapholunate and lunotricutal ligaments are assessed via these mid-carpal portals. So this is the picture showing the 3-4 portal and the 6R portal. So this is the attachment of the scapholunate ligament, where the dorsal is the more important, stronger part, and the volar is relatively weaker part. And the way it is attached will reinforce the joint at the scapholunate junction. What happens in a radial styloid fracture, the Schoffer's fracture, is there is the high likelihood for it to get injured, and there is this scapholunate injury which can cause diastasis at the joint. So particularly in these cases, we use the 4-5 portal because the 3-4 portal will naturally hinder the reduction. And the high incidence of scapholunate tears in these fractures makes it even more convincing for us to use an arthroscopy assistance to treat these fractures and the associated injuries. And we can use cave wires as joysticks to manipulate the fracture fragments. And to insert the cave wires, we can do it by using a 14 gauge needle to prevent injury to the vital structures like radial artery and the superficial branch of radial nerve. So this is the first scope picture where after reduction, there was an incongruity, and this is after arthroscopic assisted reduction of the articular surface. So this is a classification given by Giesler. and it is for scapholunate instability, and it is an arthroscopic classification. This what we see here is the lunate, and this is the scapholunate ligament. This is scaphoid, and so grade 1 is just an attenuation or hemorrhage of the interosseous ligament, which is observed from the radiocarpal space, and there is no incongruence of the carpal ligament in the midcarpal space. So these cases, these injuries can be treated conservatively by immobilization. And grade 2 is along with this hemorrhage, there is incongruence of the or step off as observed from the midcarpal space, and the step off is not much wide; it's less than 2 mm. It is grade 2. So these are treated by reduction and pinning. And if it is more than 2 mm, it is grade 3, and we use an arthroscopic reduction with pinning or repair of the ligament. And grade 4 is the drive-through phenomena, which is seen where there's the 2.7 mm arthroscope passes through the gap, and there is gross instability, and it is indicated to do an open reascension of the ligament or ligament reconstruction. So this is again a recap of the same. Grade 1 is just hemorrhage of the interosseous ligament, and there is no midcarpal instability, and there is no step off. Grade 2 is incomplete partial or full substance tear, and there is slight gap less than 1 mm probe, and there is midcarpal step off. And grade 3 is ligament attenuation, incomplete partial or small full substance tear. Here the probe can pass through the carpal bones, and there is midcarpal and radiocarpal step off. And complete tear is gross instability. There is again step off both midcarpal and radiocarpal. So this is a midcarpal view. This is the Geisler type 4. This is the drive-through sign being positive. And this is again a midcarpal view with lunotricutal injury, where the probe is being inserted and between the tricutum and the lunate. So again, these have 4 grades, and grade 1, 2, 3 can be treated by immobilization, and grade 4 injuries needs arthroscopic debridement and percutaneous spinning and immobilization for 8 weeks. So this again arthroscopic pictures are the same as scapholunate ligament. This is using a RF probe. They use ligamentoplasty. They do this ligamentoplasty in the bone of the attenuation of scapholunate ligament. And this is the drive-through sign being positive. This is grade 4 Geisler. And this is the associated TFCC injury that's being repaired there using PDS suture. So TFCC tears, this is a classification that's being used, Palmer classification. So just briefly about it, just 1 are traumatic tears and 2 are degenerative tears. So 1 has A, B, C, and D. A is a traumatic central tear, B is traumatic ulnar side tear with concomitant avulsion of the styloid process. Is the most common variant that occurs. And C is traumatic peripheral tear, and D is traumatic radial sided tear. So this is the radial sided tear. And the 2 entity is all degenerative tears, and 2A is degenerative thinning of the articular disc, and 2B is this confined to the lunate or the ulnar head, and 2C is perforation of the articular disc at the lunate or the ulnar head, and 2D is associated with tear of ligamentum lunotricutum, and 2E is associated with lunocarpal osteoarthritis. And this is the ASTRI classification. This is for the ulnar side TFCC tears. So this has five classifications. The first one is tear of the superficial fibers. 2 is superficial and deep fibers, and the third one is tear of deep fibers alone of the radial ulnar ligaments. And 4 is an unrepairable tear with complete ulnar side tear of the radial ulnar ligaments. And 5 is ulnar side tear of the radial ulnar ligaments, also associated with DRUG osteoarthritis. So this is a recommended algorithm for all these tears. Patient after fixation of the radial radius, we see for DRUG instability, and if it is positive and there is osseous avulsion of TFCC, we use an osteosynthetic refixation. And if there is ligamentous tear or TFCC, if it is Palmer 1B or Adzite 3, use an arthroscopic or open transosseous refixation using a suture anchor. And if it is Palmer 1B or Adzite 2, use an open anatomic transosseous fixation for athletes and adolescents. And if the TFCC is insufficient with dorsal instability, use a dorsal capsular imbrication. And even there is multidirectional instability with insufficient capsule and sufficient TFCC, we use an Adams procedure. So Adams procedure is nothing but using of palmaris longus tendon through the dorsal palmar bone using a drill hole at the ulnar side of the distal radius, and again getting the palmaris longus tendon through this, and again fixing it at the ulnar side at the fovea with an interference screw. So again, arthroscopy can also be used to debride the fibrous tissue that's being formed at the time of implant removal. So that will also improve the range of motion and the functional scores. And this is an RCT by Sellis et al. And they had found that the patients who were treated with arthroscopy and the patients who were treated with open reduction fixation alone did not have better outcomes when they were treated with arthroscopy, additional arthroscopy. And their 3 months course of the patient reported outcome scores were even worse when they were compared with the open reduction fixation alone group. And although the functional outcome at 12 months, they were similar. So the initial immediate outcome scores were poor, and they concluded that they would not recommend arthroscopy assisted procedures for surgically fixing the distal radius fractures. And this is a level 1 evidence study, and it is a multicentric study, and with 50 patient follow-up up to 1 year. So some points about dry scopy. So dry scopy is to prevent compartment syndrome because we don't use any fluid which can cause the extravasation and cause increased compartment pressure. And the important disadvantage in this technique is there is potential splashes that can occur when you use the working portal to debride or shave, and there is loss of vision and the surgery can delay. And patient can switch to wet scopy when thermal probes are indicated, and again come back to dry scopy. And if needed, a pump pressure of 15 mm mercury can be used as well. And the depressed fragments are mobilized with either a probe in the joint or a FREER elevator. And again, KBS can be used as a joystick. So this is to put some perspective of how dry scopy works. So this is a cadaveric scopy, and they found, so this is after dry scopy, and this is after a wet scopy. So see the amount of fluid extravasation and the skin that gets damaged, and dry scopy, it's much more better. And in dry scopy, we use free flow air at all times because suction, and there is open to the air and the sheath. This is the article which recommends pearls and pitfalls to use this dry scopy, and he has over 700 dry scopy experience in his lifetime, and this article is really good. I would recommend all of you to read this once, please. So this is where he used a irrigation tool to increase visualization and to reduce the splashes that can occur during the debridement or during the working portal. And during irrigation, the suction can be on, and otherwise suction need not be on. And so the valve of the scope should always be open at all times, and the suction and shaver burr should be closed except when needed. And the joint should be irrigated as well as needed to remove debris and blood. So this is the FCR approach that he uses. And this is the FCR tendon sheath. And this is the initial fixation with temporary K wires. So what he does is he uses the scope in 6R portal and works from the ulnar side to the radial side, individually fixing the fragments, and uses this K wire to temporarily fix after elevating the fragment, the depressed fragment, using a hooked probe, and then fix it to temporary K wires, and then do the definitive fixation with screws. So this is the illustration depicting the same. So initially the depressed fragment gets reduced back using a hooked probe and then gets fixed using locking screws. So this is again the arthroscopy images are the same. So that is the hook probe being dipped under and hooked onto the depressed fragment and then fixed, showing a good cortical congruity. So this is again, this is how he works. The 6R portal being the viewing portal and uses the 3-4 portal as the working portal and works from the ulnar side till the radial side. First, the ulnar side of the radial radius is fixed, and then the whole of the other fragments are fixed. So this is how it looks in the scope in 6R position. This is the scaphoid fragment, the dorsal lunate and the volar lunate fragment. And this is the before reduction and this after reduction. And this is the scope in 3-4 fragment to confirm the, again, incongruity. So the take-home message is this arthroscopy assisted reduction of fractures and fixing it has an exponential learning curve. So it requires substantial arthroscopic training, particularly in the most comminuted cases. And the paradox is that the cases that benefit most from the arthroscopy are the most complex cases, more comminuted ones. And one has to have a clear understanding of the anatomy and the relevance of the individual fracture fragments, and has to be aware of associated soft tissue injuries which can be addressed using arthroscopy after the fixation. Thank you, sir.
Thanks, Rahul. As you said, no, very difficult situation because arthroscopy in the setting of a trauma is absolutely difficult for, first of all, for viewing. The important fact about doing arthroscopy assisted distal radius fracture is it has to be done as a dry scopy. If you use fluid, then there is very high chance for developing a compartment syndrome. Second thing is without the use of fluid, then there is the splashing which occurs, and visualization becomes a difficult issue. Usually used for distal radius fractures along with scapholunate injuries. Those are the conditions where it benefits. I do not have any personal experience in doing arthroscopy assisted distal radius fixation. Whatever talk I have listened to Dr. Darshan's talk in Bangalore, he insists on starting it the simple way. If you want to learn arthroscopy assisted distal radius fracture, first learn it for simple fractures like the die punch fractures, where the articular fragment is depressed. So you can do a dry scopy, elevate the fragment, and then put a plate. Next most important thing is use of C-arm guidance. We cannot use the traditional C-arm which we are having. It's a bulky device. It will always be difficult to maneuver it. You need the mini C-arm. The use of mini C-arm or the mini portable C-arm is the one which is needed for visualizing or marking the portals and then proceeding with arthroscopy. So these are the two essential things that is to be taken care of when you're doing an arthroscopy assisted distal radius fracture fixation. And take home message is, if you want to learn it, you have to learn from the simple fractures, and then you can proceed to the complex scenarios.
So I have a question. Does the future look good for this, sir, for arthroscopy assisted reduction?
If you ask, does the future look good for a FAI, scopy for an FAI? Can we answer it? It's always, there is a role for arthroscopy. There is a role for arthroscopy, especially in distal radius fractures, which are comminuted and depressed. See, there are complex fractures which needs X-fix fixation, right? So it's always better to use arthroscopy as one of the major device in achieving the reduction and maintaining the reduction with all the means that are possible. There is a role for it, but see, in our patient population, the indications are there, but the usage is limited because of the cost constraint and patients' awareness about the benefit of this procedure. So in our scenario, may be limited.
Okay, sir.
Sir, is my screen visible?
Yes, Arjun.
Okay. Good morning. Today, I'll be talking about design rationale in total knee arthroplasty process. In before sessions, we had discussed about the evolution of TKR implants, how to take proximal tibia cuts, how to take the femur cuts, how to position the component. In today's talk, I'll be discussing about the native knee kinematics, some key aspects in implant design, classification of implant design, and we'll be looking at some of the implants at a glance, and I'll be presenting some interesting registry data. So the initial implants, initial TKR processes in the late 70s and early 80s were based on the four-band link theory by J. O'Connor. As per this theory, there are four links: the surface of tibia, the surface of femur, the PCL, and the ACL. The center of rotation was the intersection of the cruciates. So the flexion of the knee, it produced a rollback and posterior shift of the center of the rotation from the extension. So these are generally J-curve femoral components. So further work by Freeman, Pinskrova, and Nakagawa around 1990s and 2000s, they brought out the differences between the middle and lateral compartment of the knee. So if you, in coronal plane, if you notice the picture there, the medial femoral condyle and lateral femoral condyle are not symmetrical. The medial femoral condyle, it projects more distal than the lateral. Similarly, the medial tibial plateau, it is more distal than the lateral. So there is a asymmetric joint line with medial joint line more distal than the lateral. And if you look at the sagittal plane, the medial compartment, the distal medial femoral condyle is more distal and posterior, and the tibial plateau is concave. While at the same time, the lateral femoral condyle is more anterior, more proximal. The tibial plateau is looking convex. So medial side, the joint is more congruent, more stable, and the lateral side, the joint is less congruent and more mobile. So in this, again, in the sagittal plane, I got two circles. The blue circle represents the distal femur condyle, and the red circle determines the posterior femoral condyle. So if you notice the difference between the lateral femoral condyle and the medial femoral condyle, if you notice the center points, there is the distance between the two center points is much more in the lateral femoral condyle than that in the medial femoral condyle. So the difference in radius of curvature drives the posterior rollback. In axial view, it is not exactly hinge joint. Some degree of motion is there. If you notice the medial tibial plateau there, the medial tibial plateau is larger and longer than the lateral tibial plateau. So because of the femoral geometry, as the knee rolls back, medial side moves less than the lateral side. So the contact pressure of the femur condyle is marked on the medial tibial plateau and the lateral tibial plateau. If you notice that in the initial degrees of flexion, it is either a lateral pivot or an equal pivot. But as the flexion progresses, like in activities of which involves deeper flexion, like squatting, there is more posterior translation in the lateral tibial plateau when compared to the medial tibial plateau. So there is a medial pivot which is happening in the deep flexion. Now, there are two important mechanisms, the femoral rollback and the screw home mechanism. In deep flexion more than 90 degrees, the contact points, this is the contact point here, it is rolls more posteriorly to avoid impingement between the posterior femoral condyle and the posterior tibial condyle. So this permits more flexion. Also, at the same time, tibia internal rotates during this mechanism due to the geometry. Now, this movement, it occurs due to the PCL and the geometry. The second mechanism is the screw-home mechanism. When the knee goes to terminal extension, the tibia externally rotates, improves the extension stability. ACL is said to have a key role in playing ACL has the key role for the screw mechanism as well. So if you see in these pictures, what we are doing in TKR normally is we are trying to replace the asymmetrical femoral condyle with symmetrical component. So if we are restoring the medial joint line, like in this picture, if I am restoring the medial joint line, then the lateral joint line will be distalized. But actually what we want is asymmetric femoral components, so that both the lateral medial joint line and the lateral, both the medial joint line and the lateral joint line are restored. And this might be the future of the TKR process. So how do we design TKA implants to do the same? To recreate the natural joint kinematics, it's very complicated and it's very difficult. So let's discuss about the femoral geometry, the radius, the sagittal radius of curvature. Based on the sagittal radius of curvature, based on the femoral geometry, the implants can have single radius, multiple radius, or gradually reducing radius. In variable radius implants or the multi-radius implant, they have a J curve. It includes most commonly used designs, which we use like PFC, Sigma, Gen 2. Most common designs have this variable radius. So on sagittal view, there's a large radius anteriorly and a smaller radius distally and even more smaller radius posteriorly. So the aim of the smaller radius of curvature posteriorly is to increase the freedom, allowing more femoral rollback. In single radius femoral geometry, it comes with triathlon, basically from processes from Stryker, triathlon and Scorpio. They have a uniform radius of curvature from 10 degree to 110 degree. This is based on the principle that superficial MCL is isometric and there is uniform flexion arc centered around the transepicondylar axis. So, but the studies comparing both of them saying that says that there is no, this is a recent meta-analysis published in 2020. It says that there is no statistically significant differences between the single radius and multiple radius femoral component designs in terms of post-op functional outcome. And let's discuss about the conformity. So the degree to which radiofemur and polyethylene conform with each other is known as a conformity. In the first picture, there is less conformity, but there is more contact stresses. So more contact stress leads to more linear wear. In the third picture there, it is very much, more conformity is there. So there is lower contact stress, but it can lead to more volumetric wear and debris. But with our highly cross-linked polyethylene, the wear and debris will be less. So let's discuss about the constraint ladder. More the constraint ladder, more the constraint, more is the chance of early loosening. So this is the CR implant. We have at the lowest point of the constraint ladder, followed by PS. PS is also classified as unconstrained processes. Then there is a constraint like the TC3, the rotating in simple hinge. So increasing the constraint, more force is transmitted to the implant semen interface. So when the constraint is increased, we have to keep a stump there. So let's classify the TK implants designs which are available at present. It can be non-constrained, which includes CR, PS, anterior stabilized, bicruciate retaining. They can be intermediate constraint implants, which is medial pivot, anterior stabilized, bicruciate stabilized. Other implants are constrained non-hinge TKA and highly constrained hinge TKA. So let's discuss about some of the common processes which are available. So we'll be discussing about the articular geometry, how ligaments are replaced or are going to function, and what are the benefits and outcomes and the problems of it. In CR, the articular geometry is based on flat inserts, and the medial joint line and lateral joint line are at the same level. So the PCL aids in the rollback, and there is no inherent rollback mechanism in the implant. There is no pivoting which is happening. The merits of a cruciate retaining TK is that it preserves bone. It has some theoretical, the PCL has some theoretical role with proprioception. But the problem that arises is that the PCL balancing is difficult. The tight PCL, it can result in accelerated wear. And if the PCL is loose or ruptured, it can result in flexion instability later. So let's now look into the posterior stabilized TKA. Now the posterior stabilized TKA has, the PS design has got more dished insert. This is what I intend to highlight. The inserts are more dished. There's a cam and post. The medial and lateral joint line are at the same level. There is no ACL function. The cam post substitutes the PCL. So kinematics, there is more posterior contact in extension. There is more antero-posterior translation in flexion. And rollback is present because of the cam and post mechanism, but is no pivoting, which is occurring. So the merits of a PSTK include easier balance, easier exposure, and definite rollback mechanism. So the problems which arises are, we are removing more bone, which can be difficult in a setting of a revision. Or proprioception might be decreased, at least theoretically. Then there are other complications like a cam jump. This is a picture showing the cam jump. It occurs when there is flexion, the flexion gap is loose. This is another X-ray showing the cam jump. And there can be post wear and fracture. So the wear which can occur in the post, it can lead to a fracture. Then there is another inherent complication of the PS design is the patellar clung syndrome. Because of the patellofemoral articulation, fibrous nodule is formed in the suprapatellar region, and this can result in a painful plunk. And the treatment for that is arthroscopy. The first picture is showing the nodule superior to patella, and the third picture showing the scar debridement with the scope. Another design which is available is a bicruciate stabilized. The articular geometry, the medial and lateral joint line are at the same level. There is an anterior and posterior cam which substitute both the ACL and PCL function. In both the CR and PS insert, there is some paradoxical anterior motion which is occurring, but which is not contributing to stability. But because there is an anterior and posterior cam, both the ACL and PCL are substituted, there is reduced paradoxical motion in the bicruciate stabilized knee. This is a recent publication published in 2023. It claimed that the midterm results of the bicruciate stabilized total knee compared with PS knee was very good in terms of pain and quality of living. So let's discuss about anterior stabilized TKA. Anterior stabilized TKA, it relies on the articular geometry of the insert. It's more like a CR insert with a high anterior line. So ligament function, the PCL is sacrificed without a post and cam, but it can lead to a more lax knee. The merit is that because we are not taking the box cut, it's more bone preserving. And the problem is that it can have more wear and less range of movement. And this is a publication which came in 2021, which compared the anterior stabilized knee with cruciate retaining knee. They showed similar clinical and functional outcome and greater survivorship, but anterior stabilized bearing had high incidence of mobilization under anesthesia for decreased range of movement. So let's discuss about the medial pivot knee. Medial pivot knee recreates the natural joint kinematics more closely. The joint is more congruent medially, less congruent laterally. You can see the medial joint line and the lateral joint line, they are at different levels. So the ligament function is substituted with articular geometry. So kinematics, the medial pivot is occurring in deep flexion, hence it claims to have better kinematics and merits more potent satisfaction. The initial results of this knee, it was published in 2022. It showed better clinical outcomes than the posterior stabilized total knee. This is another design which is known as bicruciate retaining TKA. This is not available in India. There's articular geometry, the medial and lateral joint line are at the same level. Both the ACL and PCL are retained, so that there's gradual rollback. But there's no pivoting which is occurring. Now, the problem with this design is that there's a technical difficulty. There's a bone island in the center because you are retaining the ACL and PCL. So the risk of bone island fracture is there. Positioning the tibia component will be difficult, and outcomes at present, it needs more data. So mobile bearing TKA, let's discuss about mobile bearing TKA. This is available in the market now. The poly rotates on the flat tibia. It has got equivalent survivorship when compared to CR and PSNE. But the problem with mobile bearing TKA is the backside wear and the bearing spin out. This is an SO model showing the bearing spin out, and this is an X-ray showing the bearing spin out. So all poly tibia. All poly tibia is also available. We recently did a case in our OT now. All poly tibia, it does not have motility. There's no backside wear. It has similar function and septic loosening. The advantage is that it is much cheaper. So the outcome of the all poly tibia component is good. It has significant improved implant survival, reduced rates of post-op infection, fracture, and tibial component loosening. And this author recommended it should be considered for most of the patients regardless of age and BMI. But the problem with all poly tibia is that if we have to change the poly, then it will be difficult. Like if we are taking the patient for a washout, something like that, or if there is poly wear, it will be difficult. So now let's discuss about the trochlear geometry. In 1970s, most TKAs utilized femoral component with a symmetrical patellar groove. But over time, use of laterally oriented asymmetrical patellar grooves became common, and the new designs have narrower and thinner anterior flange. They have a deeper trochlear groove. They're smoother. In case of PSNE, they have smoother intercondylar box transition zone. So these new designs aims to reduce the incidence of patellar crepitus and anterior knee pain. This is a study published by the Ranawat group comparing the attune and the PFC sigma. Both are processes from the DePuy. Attune, the trochlea is 3 degrees more deeper than the PFC sigma, but they showed that there was not much difference between the PFC sigma and attune knee in case of satisfaction, but the attune group had lesser incidence of anterior knee pain and crepitation. So now I am presenting some registry data when I went through the National Joint Registry of UK. This is a 19th annual report, the last annual report which came out. As per this registry, in UK, the 57.8% of the primary knee operations, still they are doing CR only. And posterior stabilized, it is accounting for 19.8%. If you see the annual report from US, in 2012, the PS accounted for 52.9%. 2013, it was 55.6%. And 2021, the usage dropped down to 42.5%. And the usage of CR has increased over the years. So the take-home messages from my talk is that understanding native joint kinematics is critical to understand implant design rationale. The aim in evolution of processes is to recreate native joint kinematics and ligament function. More the constraint, more is the stress at the implant bone interface. And implant designs are evolving and the future is looking bright. Thank you.
A good presentation, Arjun. You covered all the important points pertaining to the component design, which commonly used all over the world. But commonly available designs which we are using is the CR and PSNE, which is available in India. And the important things to remember, these are the few modifications which has happened once in 5 years, and basically to restore the joint kinematics. That is the idea, because still 20% of the post TKR with all good alignment, with good balancing, with good looking X-ray, still the patients are not happy. So that's what the designers all over the world thought of modifying, and we should mimic, or we should move more close towards the joint kinematics by doing a TKR, but still it is in a area which is not completely explored area. Basically, joint kinematics by doing a regular with a conventional method by restoring the mechanical alignment. Now, probably we should call it as a pre-robotic era and post-robotic era. That's what I should feel, because all these designs based on the pre-robotic era. So once the post-robotic, now the concept has completely changed, and the way we are looking into the knee alignment is, still we accept only the few degrees of error by the conventional method, but with post-robotics, there is many concepts like restricted kinematics and kinematic knee, or mechanically aligned knee. All these things are kinematically well balanced knee, or anatomically aligned knee. All these things are based on the robotic based plan and execution, but still the long-term data is awaited. So how it's going to behave, but till date, there is no much difference in the outcome aspects, at least in the short term, comparing the mechanical as well as with the robotic. That's what based on all these designs. But irrespective of the design, finally, it depends on how good you are in analyzing the patient's deformity pre-op, and intraoperatively, how much you are executing your soft tissue release, and how good you are in dealing with a soft tissue balancing, both extension and flexion. It makes a lot of difference. But definitely we should thank that compared to the 2000, now in the 2023, the highly cross-linked poly, which has definitely improved the outcome, because previously one of the catastrophic failure was happened because of the poly wear, because of the previous conventional poly. So all this failed in 5 years or 10 years follow. Now, at least the longevity of the implant is happening because of the improvement in the poly design and highly cross-linked poly, number one. Number two, the patient satisfaction also. We reviewed an article. It's not a 20% of the unsatisfaction group. Basically, it is a 10% of the group are unsatisfied by evaluating properly. But we should be very careful when you're dealing all those things. The first choice always in your practice, good and proper bone cuts based on the laxity and good soft tissue release, good balancing both in coronal and sagittal plane. That is the key, number one. Number two, always your first choice in your balancing, it should be a unconstrained either CRU. If you are a CR surgeon, you go with a CR knee, or if you're a PS surgeon, go with a PS knee. Because both our long-term outcomes are same, but the trend is slowly moving towards a CR knee. Probably this is because of less bone loss, and in the revision situation might help in giving a good bone structure. Otherwise, functionally both are same. And number two, always keep your semi-constrained option in the backup only. So never go for a liberal bone cuts, and you should not land up in a 13 or 15 poly. That means you have something wrong with your bone cuts and balancing. And we had one case, a high BMI patients of more than 40. Patient was doing almost 3 years well. He had one camp jump that was, we reported in a case report 2 years back. But that guy had a very highly obese guy, and he had a high deep flexion injury, and it had a one cam jump in my experience. And we had a one patellar clunk because of the, especially in the PS box design, designed by a PFC group, that is a J&J group. You must have noticed they have a big box cut. And invariably in our population, they go for a deep flexion. Slowly, this proximal tissues in the over the patella, it'll get a clunk there, and patient had a symptomatic. And we did arthroscopic debridement by Dr. Santosh, and it came up very well around 4 years back. So all these things, when you are choosing the implant and choosing the design, and you should have a good idea about all these things, which how we are going to execute and what is the outcome. And this bicruciate substitute knee is not available basically. Basically, the Korean groups, they are much more interested in the deep flexion activity, and they recommend this bicruciate substitute or retaining components. But definitely it works very well. But it's unfortunately it's not available here. But otherwise, with our designs till date, the long-term outcome is good. Yeah, thank you.
Yeah, it's over. Shall we wind up?
Yes, sir.
Yeah, okay. Thanks for attending the meeting. Gopal, if you're there, thank you very much.
Yes. Have a good day, David.
Okay.
Good topics. Enjoyed it.
Right. Morning.
Thank you, sir.
Good night.
Bye-bye.
Good night to you. Right. Take care.
Good night.
Bye. Bye.